So I'm going to talk more about the practical aspects of mobilization in multiple myeloma and lymphoma. So as we all know, at least in the United States and most likely worldwide, we have data suggesting that the number of people that we have to care for doing an autologous transplant has been going up over time. As you can see here, it's been a steady increase in the slope of this blue curve, which is the number of autologous transplants being performed in the US. And the majority of that growth has happened in this segment, green here, which represents people between the ages of 60 to 69 years. And more recently, since about 2010, the population of people getting a transplant above the age of 70 has gone up. And this is more a demographic trend and also partially a trend in the improvement in supportive care that our transplant community has wrought about in the last few years, which makes autologous transplant a very safe procedure. In addition, there are other pressures on transplant centers. So we are providing care for ever-growing number of patients and collecting cells off of them. We also have now additional pressures in terms of second transplants, in terms of patients who are getting effective regimens that put more people into remission, so they're coming more for transplant. And also there are other uses of the apheresis machine, and more recently in the United States, again, there are at least 2 drugs approved now for chimeric antigen receptor T-cell mobilization. And this, again, it would be another growing trend that impacts the availability of resources, which are limited for collection of cells. And again, the 2 major indications for transplant are multiple myeloma and non-Hodgkin lymphoma, as everyone here knows. And we estimate that there are about 13,000 cases of myeloma and lymphoma going through an autologous transplant every year, which translates to, even with a failure rate of mobilization of about 5%, it's almost 15,000 people who need to use the mobilization machine. So going to multiple myeloma. If we look at the recent trials in transplantation that have been published or are presented, the largest US trial of myeloma, including transplant, was just recently presented and now it's submitted for publication, which was known as the Stamina trial. In the Stamina trial, as is with most US trials, we actually don't specify the induction. We don't specify what mobilization to use, but we randomized patients after their first transplant to 3 approaches, either lenalidomide maintenance, which was the standard approach, or a consolidation, or a second transplant followed by lenalidomide maintenance. So this study, as you all know, did not show a difference between these 3 approaches. However, the important point here to note is that it was dealer's choice when it came to mobilization of cells. Whereas if you look at all the European trials, these are the 4 major European trials that compared the same thing. They compared upfront transplantation versus a delayed transplantation and uniformly showed a benefit in progression-free survival for upfront transplant. And in the case of the first 2, showed a overall survival as well for upfront transplant. And the EML trial is not read out yet fully, but it's already showing some improvements for tandem transplant over single, as you all know. But here again, the Europeans have tended to use an approach that includes, which specifies the induction, specifies the non-transplant comparison, and also specifies the mobilization, which in all cases is cyclophosphamide. So there is a big disparity between how these studies have read out. So many people still use, the purists would argue that the studies that have shown an improvement in survival for transplant have used cyclophosphamide in mobilization. Now let's see if that holds up. This is a recent paper from actually the most recent issue of BBMT, which was a German center that compared patients who got predominantly bortezomib-based induction strategies and then got mobilized with chemotherapy. 94% used cyclophosphamide, 6% used etoposide, and has looked at what happened to the myeloma between the chemotherapy used for mobilization and before transplant. So in that short interval, did the chemotherapy add any measurable effect to the myeloma? Did it upgrade the responses, for example? So as you can see, in many cases, the change was in the negative direction, which means compared to pre-mobilization, the kappa light chain in this case, the kappa lambda ratio in this case, and in this case, the IgA levels went up. So it really did not go up by a significant amount, but it didn't go down. So only 3% of the patients had any change in response level, which translated to a meaningful upgrade. In addition, there were 28% adverse events, including 23% with infection. So this is some data suggesting that the imposition of chemotherapy in that short interval will actually not lead to a meaningful upgrade in terms of a myeloma response level. We also have retrospective data from the CIBMTR, which compared the progression-free survival and overall survival among patients with myeloma who got mobilized by either chemotherapy with G-CSF or growth factors alone, and showed identical results. So leaving that for now, let's move on to how many cells do we need. So in myeloma, again, the important question is how many transplants, and it's that myeloma is becoming more of a chronic disease. There are more and more people getting second transplants at Salvage, and if you're a purist and believe in the EMN02 data that was recently presented at ASH, there is a role perhaps for tandem transplant. It's in a subset of patients, because it appears to be an effective strategy to get many patients to an MRD negative state in myeloma. Although the counter-argument would be that better induction would also do that, or consolidation could do that without the use of a second transplant. That debate notwithstanding, we need to collect for 2 or more transplants during the lifetime of that patient. So there is a more is better philosophy in terms of transplant, because we are transplanters, and I can say that clearly here. But more importantly, it should be more cells in more bags. So if you collected 6 million cells and you put them all in one bag, you're not going to be able to do 2 transplants, for example. So collection is one part, and how you allocate the cells for a future transplant is also a thoughtful process. So the majority of us, just as Dr. Costa said, would collect somewhere between the 2 to 4 million range for a minimum single transplant. And if you get 4 million, you could put it into 2 bags and get 2 transplants out of that. An ideal would be somewhere in the 8 to 10 million scenario, where you're putting it in 4 bags and you've got more than 2 million for each transplant, including a later transplant. Now, what are the uses of these second bags that are hanging around? One is a salvage transplant at relapse, and many of us believe that a reinduction strategy followed by a salvage second transplant followed by a different maintenance can actually provide meaningful benefit in patients. There is also another often ignored use of these cells that are in the freezer. Many patients at the end stage of their myeloma have low counts, as we all know, from repeated chemotherapy. And some of them actually cannot even get on clinical trials because of low counts, low platelets. For most trials, exclude platelets below the level of 75 or 50. And many of us successfully use these stored cells with a short chemotherapy followed by cells to improve the count so that they can get on new therapies, including some of the new monoclonal antibodies and BCMA-targeted therapies that are coming along. So having cells in the freezer, I would argue, is an important asset for any patient with myeloma, because it opens up further possibilities. Let's look at the pivotal study that was presented by Dr. DiPersio in Blood several years ago now. This is the phase 3 study that compared plerixafor plus G-CSF or placebo plus G-CSF for mobilization. And the goal in myeloma patients in that large study was to get to a 6 million CD34 cells per kilogram body weight dose. And 54% of the patients receiving plerixafor plus G-CSF got there in the first day. And overall, 86% could get there. Whereas with a G-CSF alone approach, 56% got there despite 4 days of mobilization. So this is the study that actually definitely proved that if you want to get to a higher target in a shorter period of time, the use of plerixafor in a planned fashion, this is not just-in-time plerixafor, this is planned plerixafor, would be the approach to go through. And as I said before, the salvage transplant option is an increasingly available option. Going through the CIBMTR data, we find that the use of salvage transplants at relapse has been increasing in recent times. It is almost 500 plus transplants per year performed in the United States now, and we only anticipate that this will rise as patients are have better options at relapse and can get into MRD negative states even at relapse with better treatment, which may include a transplant at relapse. So this was the randomized study from the UK, which showed that patients receiving a second salvage transplant actually had superior overall survival, and this was published in Lancet a while ago. But this study also gives us an opportunity to look at the efficacy of remobilization after a first transplant. So these were patients who were on that study, who were randomized to transplant and had to go on transplant. And the question was, could they be remobilized after they had actually had the first transplant, relapsed, and then they were ready to have a second transplant? So overall, of the 110 patients who attempted remobilization, only 50% were successful. The majority of them were actually successful in one attempt, and the approach, so these are, these colors represent various different remobilization approaches. Cyclophosphamide plus G-CSF here, cyclophosphamide chemotherapy plus plerixafor plus G-CSF over here. And as you can see, 37% got there in one attempt of mobilization. Assuming that you're going for 2 million cells and you got 1 million cells in the second attempt, another 12% or 13% got 2 more attempts to get there. And in the second attempt, you kind of made up the cells, as you can see here. And the third attempt, 75% who went there got there. But the argument is that you would do a third attempt only if you had a smaller number to mobilize to get to that final goal. You were using all 3 attempts to collect a total of 2 million. So again, if the remobilization after a relapse is possible, but not desirable, because it's better to have the stem cells collected earlier. And even if we have to do an extra day of pheresis or use a more effective agent such as plerixafor, that opens up various different options at relapse for our patients. So let's look at another scenario. This is a patient receiving 6 cycles of RVD, achieving a PR, and then coming to us for transplant. So the question here is, what does lenalidomide repeated cycles do to a PBSC harvest? These are patients with lenalidomide induction and the mean count of CD34 during their mobilization attempt. As you can see that there's a significant lower numbers of CD34 in the blood, CD34 collected, compared to any other induction therapy that was in this analysis. So the number of days of collection also is higher for people getting repeated cycles of lenalidomide, usually defined as more than 4 cycles. The other important thing to remember is that the time off of lenalidomide, if you give them, for example, a more time off, does not appear to make a huge difference, and most of us do proceed to collection after stopping lenalidomide for average 2 to 4 weeks. And this is Dr. Costa's data showing the same thing, that growth factor plus plerixafor mobilization is desirable in patients who've had more than 4 cycles of lenalidomide, since they're less likely to mobilize the desired target in a smaller number of apheresis sessions. And that seems to be correlated with the number of cycles of lenalidomide they received prior to that. So these are the guidelines from the consensus group that was put together under the leadership of Dr. Geralt. And early collection is recommended for patients on lenalidomide, and there is insufficient data to recommend a single mobilization strategy at that time, but you would need to think of something beyond just simple G-CSF-based collection by adding either plerixafor or chemo mobilization in this setting, given the lower efficacy of collection by the use of lenalidomide. These data were already shown by Dr. Costa. This is the data from UNC showing the use of chemo mobilization with etoposide. And in this attempt, they were able to collect almost 100% of myeloma patients within the target within about 2 days, 99%. However, 20% had a transfusion requirement, 17% had to be hospitalized either for fever or neutropenia. So it comes with a cost, and these costs have not been worked out. There is an ongoing prospective study done through the CIBMTR right now, where about 20 centers are collaborating, and all these centers use various different mobilization strategies, and the idea is to observe mobilization over a period of a whole year and analyze the costs in a detailed granular fashion. I would just like to mention also mobilization in AL amyloidosis in this context. This is a situation where a cytokine-only approach is preferred, since these patients are generally too sick. But the peri-mobilization morbidity and mortality is exceptionally high with repeated doses of G-CSF, which seems to induce a vascular leak. This is from our own center, where we showed that an abbreviated G-CSF regimen, reducing the G-CSF to just 3 or 2 days by adding an early plerixafor, would let you mobilize faster and have significant improvement in the risk of weight gain that happens along in these patients. So weight gain tends to predict mortality in the perimobilization phase in amyloidosis. People who gain more than 10% of their body weight during the mobilization phase are at extremely high risk, and that could be significantly reduced by abbreviating the G-CSF and using plerixafor to do that. These are the guidelines that Dr. Costa also showed, and these considerations are really to optimize resources is what I would highlight as the important thing. And the resources are specific to each institution. For example, what sort of contracts do you have with the mobilization agency? Do you do it in-house? What sort of contracts do you have for getting plerixafor? What sort of support do you have for people getting neutropenic fever? How many of your people have to travel if they get a fever? How many of the people who they got admitted somewhere else would miss their mobilization dates? These are all variables that are specific to each institution, and it's very difficult to come up with a guideline that addresses everything, especially in the United States. So I would also endorse Dr. Costa's approach of just-in-time use of plerixafor by using CD34. I would think if you had to invest in something, there are still centers that don't have a CD34 count before mobilization, and that would be the single most important thing, because that at day 4 can predict the poor mobilizers better than any of us can do clinically. These are the consensus recommendations for patients with multiple myeloma. These are in your slide sets. I'm not going to go more with that, and we're going to move over to lymphoma. Let's look at the 70-year-old man who is on therapy for diffuse large B-cell lymphoma, who gets a initial remission that lasts for about 2 years, and then obtains relapses and obtains a CR after 3 cycles of RIs. So at this point, he has completed his salvage therapy and is preparing for an autologous transplant, and a pre-mobilization platelet count of 100,000 is noted. So that's one of the risk factors for in addition to this gentleman's age, that predicts for a poor mobilization. And the risk of a failed mobilization is much higher in non-Hodgkin lymphoma compared to myeloma, especially these days, since the patients with lymphoma have been treated more with myelosuppressive chemotherapy than the patients with myeloma, who we tend to use novel agents these days. So the failure rate can be as high as 20 to 25%, and obviously higher in NHL. This is the pivotal phase 3 study by Dr. DiPercio's group, again showing that so in this study, the primary endpoint for a lymphoma patient was collection of 5 million or more cells as the target. So 27% got there in 1 day with plerixafor G-CSF, and overall 65% got there. Whereas if you did placebo plus G-CSF or G-CSF alone, only 25% could get there even after 4 days. And these data are, even if you look at a 2 million endpoint, which is the minimum required for a transplant in this setting, 90% could get there with the combination, whereas the cytokine-only mobilization, G-CSF-only mobilization would get you only 60% of the time. Now we have long-term follow-up on the pivotal phase 3 study, and this is in the EPUB stage at BBMT right now, so you can actually see it online if you want to. These are the 5-year overall survival for the myeloma patients and the lymphoma patients who were on the pivotal phase 3 study. And as you can see, there is no difference in overall survival whether you were mobilized with G-CSF alone or plerixafor. The lines are identical. This is the PFS curves, and again, they are statistically very similar, suggesting that there is no difference in outcomes even with long-term follow-up. The numbers in lymphoma are exactly the same, 64% versus 56% and 50% versus 43% for patients with the 2 types of mobilization respectively. One of the drugs that many people worry about in lymphoma is bendamustine, which is increasingly used in mobilization as a chemotherapy for patients with lymphoma. And again, these are data from a limited number of patients, 23 patients in each group, who either got R-CHOP or R-bendamustine, suggesting that the median CD34 counts are statistically similar with those numbers, but this is something that you need to be on the watch out for. The other point that I would like to highlight in this setting is that patients who in lymphoma, we tend to use chemomobilization quite a bit because there is disease-specific chemotherapy, and it's easy to mobilize after that disease-specific chemotherapy, such as DHAP or ICE, is given. This is a data set from Dr. Khoury, which suggests that patients who get a neutropenic fever in the peri-mobilization period, in this data set, about 24% who had to be hospitalized for neutropenic fever out of about 550. They had a lower likelihood of proceeding to transplant, 86% versus 96%, lower CD34 dose, and more likely to require more days of apheresis. So, there is a trade-off always when we do chemomobilization in that cytokine-only mobilization reduces the risk of neutropenia and the knock-on effect thereafter. Another important thing to remember in terms of lymphoma is that the cell dose that we use for transplant and the outcomes. There has been a lot of interest in this. As we all know, immune reconstitution takes different time periods for different types of cells. In the case of B and T cells, may take a year or more. NK cells, much faster. Dendritic cells, somewhere in between, etc. One of the things that have come through in a analysis, both done by the CIBMTR and here in this meta-analysis done by Dr. Sauter, suggests that a higher CD34 dose in lymphoma especially seems to offer a PFS and overall survival benefit, and we don't really know the mechanism for this. That could be early ALC recovery, which has been predicted to, which has been shown to predict PFS, or an immune recovery. But these are all retrospective data, and the major problem is the obvious one in that people who collect more could have had something biological that determined their outcome, not the number of cells per se, but the fact that they could mobilize more cells would be the predictor. So to address that, there's a randomized study that ongoing right now where patients with lymphoma are randomized to a standard of care approach versus an approach using additional Plex and collecting more than 7 million cells and using that for transplant. So this study hopefully will give us the answer, and it's led by Dr. Sauter from Memorial Sloan Kettering. Similar data to myeloma using Etoposide chemotherapy. Here again, the success rates are good, but as you can see, there's a 32% transfusion requirement and a 6% hospitalization for fever and neutropenia. So this is the most widely prevalent approach in the United States these days by adding Plex to a person whose CD34 count is predicted that they would not collect quickly. So these are the median increases in CD34 peripheral blood circulating by the addition of a single dose of Plex from the pivotal study. So as you can see, it leads to a 5-fold increase in CD34 counts in the blood, which then leads to a higher mobilization. Most centers use a 10 cells per microliter as a cutoff to give Plex in this setting, and that can give you an optimal a cut point between using more apheresis time versus not using too much Plex and running up the costs in that regard. So this gives you a balance of both worlds. And when we did a recent survey for our prospective CIBMTR study, that we found that this is a technique that most centers in the United States use at this time, because we are competing against various resource crunches on various ends. There are other emerging data for other agents and for the use of intravenous Plex, which reduces the time for CD34 count increasing. So you can do it in the morning of the first apheresis instead of doing it 10 hours before as in the label. And also we need to be on the watch out for other common conditions that limit mobilization. There are various other agents either in development or that are already out there, such as, for example, bortezomib, which is an agent that seems to increase hematopoietic cell mobilization efficacy, parathyroid hormone, other agents that address the SDF-CXCR4 axis, which are in development, the agent natalizumab, which is a VLA4 antagonist. So these are all agents that are in development that might change the space in different ways, and it's important to keep track of those. These are the consensus guidelines that we referred to several times. Again, steady-state mobilization may be associated with G alone, may be associated with higher failure rates, but both Dr. Costa and I endorse the approach of just-in-time plerixafor by identifying the people early who are at risk of mobilization failure, and this then avoids the chance of them having to come back for a second mobilization later on. And we limit the use of plerixafor to people who are at high risk for mobilization failure. Chemotherapy mobilization obviously has an important role in lymphoma because disease-specific chemotherapy is an integral part of how we treat lymphoma. And if we can add that, add mobilization at the end of chemotherapy, obviously that is useful.